I'm curious to know, since they're looking at CAR T at earlier and earlier in the treatment continuum, whether there's any sense, either theoretical or observational, about subsequent to CAR T on relapse, whether the CAR T would affect, either positively or negatively, sensitivity to treatment, pharmaceutical treatments, presumably.
Yeah, so that's a good question. So we know that CAR T cell therapy as such is not a curative therapy. So even when we're using it in the late lines, we do have patients who've got a CAR T cell therapy. They've had a remission for an extended period of time, and when the cancer comes back, we use another CAR T cell therapy as such. So the main reason CAR T cell therapy stops working is because the T cells get exhausted. So there is rationale of even using CAR T cell against the same antigen if the T cells are otherwise fit. But in fact, in one of the slides that I showed, Arlocell, which is a CAR T cell product that is directed against other antigen, which is the non-BCMA antigen, it's directed against a different antigen. They have included patients who've got prior BCMA directed. So I do anticipate that we will be sequencing one CAR followed by another. Hopefully there'll be years in between these two therapies.
So of course I got to share with you about bispecific antibody, and the question is always, so what first? So luckily we have some data to show that whatever strategy is used first, when patient progress, you're not having your door closed to be able to receive a different technology subsequently. Now the data is still based on small number of patients, luckily, because a lot of patients are going to be in remission for a very long time. But there are already data to show that the bispecific antibody can rescue some of the patients who have had CAR T, and vice versa. Now, on the bispecific side, of course, there are already more than one target that's being evaluated, right, that has already had an approval and more to come. So if the problem of the progression is not because the T cells got exhausted, but rather the cancer cells decide to down-regulate, to hide the target where the CAR T cell need to grab onto, you would in theory be able to look for the bispecific antibody that grab onto a different target. So I'm hoping that this is a message that sometimes waiting for the right treatment is all about having the right treatment at the right time. If the progression is fast, it's not safe to keep waiting for T cell production, go with the bispecific. If patients don't have enough family support, can't be in the hospital for a long time, cannot go to big centers like Dr. Mahan Center, for example, get your cancer under control, because a lot of these are going to actually still become available down the road. I also shared that there are even newer bispecific and trispecific antibodies, and guess what? They're also the CAR T cells that are under development that are going to bind onto more than one target. So a lot of these are going to come at us fast and furious, and hopefully we'll have more data to be able to share as more patients are getting treated.
Thank you. So we're learning more and more about mechanism of resistance, right, to these cellular therapies. But one case comes to my mind where there was a patient who was treated with CAR T, and after a year or so, he relapsed and was treated again with the same CAR T and didn't respond. Now, almost immediately, he received a bite against BCMA, and he did respond to the BCMA. So that tells a couple of things. In myeloma, not necessarily the target disappeared, right? It's not gone, and seems to be more mutational, right? So just the question that if a bite, even if it's at the same specific target, might be useful, the answer to that is appears to be yes. And the reason to choose one over the other and to start with CAR T or BiTE is still a topic of debate. I personally believe that exposing a patient to the constant pressure of a BiTE over a year and a half, and then expect that the CAR T is going to work right away might not be as realistic as having a CAR T and having relapse a year later and then try a BCMA. So also factors like the patient needs the treatment right away, cannot wait for manufacturing, so I have something out of the shelf. So many factors involved, and that's why it's so important to talk to the physician to have this conversation.
Hi. I would like to thank Jenny, first of all, for organizing such a wonderful seminar. My question is for Dr. Gertz. I was diagnosed with MGRS initially. My PET scan and every other test didn't show anything until Dr. Derman went out of his way and ordered a bone marrow biopsy, which surprisingly showed 50%. My question is, how come we don't have enough literature and information about MGRS out there? Everybody is talking about multiple myeloma, MGUS, smoldering myeloma, but we don't know anything about MGRS, even though it can be as bad as multiple myeloma.
Yeah, well, I don't agree. I think there's actually quite a bit of material. Everyone sitting at this podium knows about this syndrome. In your instance, I'm surmising that there was probably light chain damage to the kidney tubules leading to the recognition, which actually is multiple myeloma. It's the R in CRAB. I would say that 15% of myeloma patients present because of damage to their kidneys. I think this is actually very well recognized syndrome, and so I think your primary tenet of people don't know about MGRS is not correct, actually. The only other thing I'd mention is that some people present with kidney damage and high plasma cell count, and the actual cause is amyloid of the kidney. One has to be aware of that possibility. But the association of myeloma and damage to the kidney, I think it's been well recognized for 60 years.
Thank you all. When you're looking at treatment options and you look at statistics and they say that your progression-free survival is this much, you're going to have this much more progression-free survival, but your overall survival isn't any improved. Is there an advantage to going with that treatment if you're not going to have an overall survival?
Let me do a quick one on that because I'm cutting out pretty soon. So think about what progression-free survival means after your initial therapy. For most patients, that means 1 pill 3 weeks out of 4. And if your progression-free survival is 2 years longer, you're going to be on that 1 pill, usually lenalidomide, Revlimid, for that 2 years. If you relapse 2 years earlier, there's no one sitting at this podium that isn't going to give you 3 drugs, which you're going to be on for 2 years longer. And you have to think about the quality of life, maybe not overall survival, which I'm not sure there isn't. It just isn't proven, because there's so many different salvage therapies that what does progression-free survival look like? For most people, that's maintenance with a single drug versus active therapy in relapse, which is always 3 drugs. Usually 2 of them are intravenous, and that has a very different effect on your overall quality of life.
Can I ask you a question also while we still have you about precursor conditions? Where do you see the field heading? You see, and then pass it to the group maybe, but you see a new approval potentially coming in smoldering myeloma?
Yeah, I think that the ODAC is going to approve daratumumab for maintenance therapy. I think that's going to be a big mistake. I think that the data for the use of daratumumab is profoundly flawed. When you look at the data, looking at it for treatment, at 6 years, 38% of the patients who didn't receive daratumumab still hadn't developed myeloma. That suggests to me a lot of people are going to get overtreated. Number two, according to the way the protocol was designed, patients who were not on treatment, who were observed, whose protein was rising like this, could not cross over to receive another drug because they hadn't developed CRAB criteria. And that's not how most people practice. Most people practice by, if things are rising, they're getting kind of skittish about treatment. But the big thing in this trial was that the patients who were in the control arm, when they developed active myeloma, how many of them had access to daratumumab? That's really important, since in the daratumumab arm, everyone got it. So how many got it in the non-daratumumab arm? 15%. So this is not a comparison of early DARA versus late DARA. It was a comparison of DARA versus you never get DARA.
Yes.
And then they showed a 5% overall survival advantage, and we're saying, success, we're all good. What we're really looking at is drug acquisition here. And so, as far as I'm concerned, I will continue to counsel patients for close monitoring. FDA is going to approve it. I have very little doubt, because the people on the ODEC panel are all enthusiasts in this area. And the naysayers aren't going to be there. But when I saw that only 15% of the control group actually got DARA, I was sick. And I go, so this is how you're going to decide that DARA helps? It really is, you got it in the first place. So,
And then strategies for just preventing progression. Can we talk about that? Because how do you identify? Do you just monitor people? Do you intervene at all?
It depends. This is not a one-size-fits-all. Obviously, everyone's getting, there's other risk factors we're incorporating. We know what the fish is. We know what the percent plasma cells are. And so we're deciding, are we checking every 6 weeks, every 3 months, every 6 months? How often will we be doing imaging? In the daratumumab trial, it was very important. They demonstrated with frequent MRI, they actually were able to prevent complications. What they showed in that trial, which, quote, people develop myeloma, there were 28 patients who developed bone disease. Of those 28, 25 were just MRI changes. Only 3 patients had symptomatic bone disease. I mean, pain, that sort of thing. 3. That's a lot of people to treat to prevent 3 symptomatic bone. There was not a single patient in the daratumumab trial, not one, that developed myeloma kidney or MGRS. 0 with the monitoring, which kind of makes sense if you're watching them super close like that. And so it demonstrates to me that it is possible to carefully follow patients and intervene without complications, because once you start with DARA, even though it's fixed 3 years, you know what's going to happen. Then they're going to get low IgG. Then you're going to have to give them IVIG infusions. Then they're going to have a reaction to the IVIG with a fever and a rash and the call. I mean, there's a lot of baggage that comes with this before we say, hooray, look, DARA prevented the development of myeloma. It's much, much more subtle than that.
Okay, other thoughts?
No. I don't think that we're going to have too many other thoughts. I mean, I could have not said it better. As soon as I saw the trial, I was a little bit concerned about the rate of infections as well. And in my mind, I thought we're going to be treating more patients than we should have. And I 100% in agreement. I think that close monitoring, I know that is psychologically kind of difficult for patients and physicians just to sit tight and wait for something to happen. And I mean, we have trained to always intervene, and we have to do something. But I think that in this group of patients, absolutely, I push for just watch carefully, go with close monitoring, and prevent complications.
Who will progress? That's
38% in that trial of high risk did not have myeloma at 6 years. They could have done nothing, 40%. The others did progress, I get that. And so they got treatment for what? To me, they got treatment for no reason at all, those 38%.
And I think we need to also be careful in that, of course, unfortunately, this is our probably also a group of patients that when they are diagnosed with symptomatic multiple myeloma, we really don't have clinical trial where those patients can go on if they have already had anti-myeloma therapy, even if it was for smoldering. And as Dr. Gertz said, these are actually the group of patients that don't feel bad a day in their lives from their plasma cell problem. And then all of a sudden, their life's going to change quite a bit to need to be on treatment for extended amount of time. And oftentimes, there are two groups of patients with smoldering. The group that's actually, they're not truly smoldering. They're edging up every time you're checking their labs. Those are probably the group of people who, if they were going to be myeloma, they wouldn't just get the DARA. They'll get the 4 drugs that everyone gets. So you could be under-treating some of them. You just kick the can down the road because you actually got rid of some of the tumor cells. Eventually, they're going to progress. And then there's another group of patients that they just come back to make us look good because they never progress. And I have not done anything. I have inherited those patients from their retired doctors. So what we want to understand is what happened in those patients. Their immune system maybe have been able to sustain and control the expansion of the clone. At the end of the day, there needs to be an understanding for which smoldering and why, right? Rather than sort of we're going to treat all of them because they meet particular criteria. Everyone's myeloma is different. Everyone's smoldering myeloma is different as well.
I think to add what my colleagues just said, our standard practice at MCW is also to offer no treatment. If there is a clinical trial that our patients can go on for smoldering myeloma, I typically offer them, or I usually refer a patient to another center that offers a clinical trial for smoldering myeloma. But outside of a clinical trial, we don't offer any treatment, but we do follow our patients very closely because with follow-up, we really understand the tempo of disease. Like, those smoldering myeloma that are impending myelomas will manifest in the first 1 or 2 years.
And I will just add, like Dr. Gertz mentioned initially, that it is difficult to make a diagnosis with one single shot in one single visit, especially in cases like this one, right? To expect that we can predict the future, what's going to happen for many years to come, because I saw you once and your bone marrow biopsy showed 52% plasma cells, or you have an IgA subtype, which is some of the criteria that the trial used. I believe that will be more meaningful, the kinetics of that protein, right? If you follow over time how that protein is behaving, maybe I will have a stronger case to say, you know what, let me intervene now before a complication happens. But just because I saw you with the characteristic that the trial quote, that they claim it is high risk, and it is high risk, right? But just based on that single visit, I think that would not be appropriate to just start you on a medication that can bring complications, and I think that are better ways to make that assessment.
Now, on the other hand, you should still keep an eye out for, of course, why do we even care to treat smoldering myeloma? Because there's a belief that if you intervene early, there might increase the chance of cure. The reason to be cautious here is it doesn't look like daratumumab will offer a cure. It looks like it actually delay the onset of the disease. Now, as our treatments improve, this whole thing that we talked about can be entirely different, because if you have a treatment that's going to be good enough to eradicate the tumor clone very quickly and suppress those tumor clone from coming back for a very long time, now we're reaching the cure word, which is what we all want. It's just that when we're using a strategy that is not perfect, and yet based on a few hundred patients, we're going to start treating thousands of patients, I think we need to be careful that positive results on clinical trial, it was a test versus the no treat versus no treat, without a longer term goal in mind, right? But stay tuned, because I think immune therapy may change everything that we say.
Okay, what other questions?
Okay, I'm smoldering right now, and I've been having a lot of bone issues. You say that it's asymptomatic, but I've had a compression of my L4, L5, and I had surgery on that, and while I was resting for 2 months, I ended up with a fracture on my L2, and then later find out, okay, well, you have osteoporosis and now on Timlos. How do you interpret situation like that and say that it's asymptomatic, which I know that all of this came with my smoldering diagnosis. I started out with MGUS. I'm confused as ever, and I just feel like the watch and wait is driving me crazy because I'm in pain every single day. So what do you say to your patients in a situation like that?
Right. And I think this is really where smoldering myeloma isn't the same thing for everyone, but I think the key thing, though, is to first truly understand whether this is smoldering myeloma or whether this is actually symptomatic myeloma that's already causing problems to the bones. It used to be that we didn't have great tools to look at bone problems in myeloma. We just x-rays you head to toe, and you show up getting flipped around on the table 14 times. That's the picture. That's called skeletal survey. Some of you probably have had those. Now, though, with ability to do much better bone imaging, PET-CT, PET-MRI, those have identified group of patients that we have labeled as having smoldering myeloma because we didn't see their bone lesions. When we used better tests, we saw it. So that would also be the first thing to resolve the issue, right? Because if someone has symptomatic myeloma, you have to get rid of the reason that caused bone breakdown. You cannot just fix the bone. On the other hand, it is true that smoldering myeloma patients, the cancer cells are sitting there and they actually like to have extra nutrients. So what do? They actually wake up the bone cell type called osteoclasts. And those osteoclasts, usually they should be pretty quiet. But when they wake up, they actually release nutrients from the bones. They are the bone sculptors. They resorb bone. So patients can have accelerated bone loss. So they end up with thin bones, with osteoporosis, with collapse. So anyone who's having early onset osteoporosis, this is where it's also important that the orthopedic doctor, the endocrinologist, also look for causes, right? They can't just blame aging when the bone loss is so unusually bad comparing to average age. And if the treatment's not very successful, if you're giving those bone strengtheners for osteoporosis and you're not seeing improvement, you have to look for other causes. And so I may not have the specific answer for you, but classically, patients with smoldering myeloma should not have significant symptoms. If the body dysfunction relates to the amount of the abnormal cells or what they make, that's actually when people like us would sort of trying to find the reason to treat, right? Because then there is the benefit in treating to prevent further damage. If the symptoms were not caused by the plasma cells, you can end up in the situation that we're still following the plasma cells. We are fixing the problem we can fix and see just what transpires. So I think hopefully with more follow-up, we'll understand better how to serve you well.
Yeah, I mean, first of all, I'm very sorry to hear that you're going through that journey, right? And I hope that you find healing pretty soon. Now, when we come to a diagnosis of multiple myeloma from a smoldering perspective, the intention is to then intervene in a way that is beneficial and take care of your symptoms. The worst thing that we could do is to blame prematurely a condition that you might not have, and then my daratumumab is not going to help with your osteoporosis, and you're going to have osteoporosis and a CMV infection with the complication that might come from that intervention. So my recommendation, because of course you need a thorough evaluation and look into those risk factors that are associated with high-risk smoldering myeloma to start with. IgA subtype, I mean, what is the percentage of plasma cells? What are your light chains, for example? And then do a thorough bone evaluation with MRIs of the spine, MRI of the pelvis, and see if indeed we do have signs of multiple myeloma, because then the treatment most likely will bring some benefit. Otherwise, I mean, I understand the desperation, and in your mind, there's a hope, and why they're not giving to you, because you are sure that once you start getting those drugs, your osteoporosis is going to get better, but that's not necessarily true. So that's why you need a very thorough evaluation right now.
I'm also watching the game, so I was told that makes it considered high risk or
I'm
1Q gain? I have a genetic
The fish
One.
1Q.
Overexpression of 1Q, yeah. I always remind patients that, risks are depending on the medication that we have at this point in time. And some of the medications can overcome those mutations. And there's data in some of these interventions that can overcome that 1Q overexpression. There's kind of changing a little bit the high risk definition. But certainly, yes, it's one of the mutations that was adopted like a high risk.
Hey, thank you for the wonderful presentation and also for having us here. I want to ask a question in regards to the neurotoxicity. Since we have an idea that there is 6% incidence of patients having this neurotoxicity, I'm just wondering whether is there any way we can add some sort of additional medications to help slow down the progression of them not having this neurotoxicity?
That's a good question. So the delayed neurotoxicity, it's rare, but obviously it's real and it occurs later. So that's what you're referring to, right? So there's a lot of interest in understanding who are those patients who are susceptible to this. So there's a recent study that showed that it's perhaps in these patients, you have this rapid CAR-T expansion. So how do we detect it in a clinic setting, right? So we look at something called a lymphocyte count. So we do get them every time you go for your labs following CAR-T cell therapy. So there is some literature that suggests now that if you have a high lymphocyte count, the numbers can be anywhere, 3,000, 5,000. That's the literature is. This is very early, so we know that somewhere in between 3,000 or 5,000, the lymphocyte count is going up rapidly, and if it is at that stage, like 3,000, 5,000, the tempo, right? So those are the patients who are likely to develop, these toxicity later on. So there is some interest in giving steroids when this lymphocyte count hits that 5,000 or 3,000, something like that. We really don't know what is the right cutoff. We don't know what is a dose of steroids. These are this is really very preliminary, But that's what I do in the clinic, because based upon this, these studies that we have, when our patients get CAR-T cell therapy, we get labs every single day for the first 14 days. When I see the lymphocyte count is going up, and we do it every day, right? So we have a trend documented already. So if I see that it's going up, if there is concerns for unrestrained lymphocyte count elevation, I do start dexamethasone. And we have data that says that if you use dexamethasone for whatever, CRS, ICANS, or whatever, it doesn't really affect the long-term efficacy of the CAR. So I do steroids preventatively for a short duration, somewhere between like 3 to 5 days, I do that. Again, this is very preliminary, and this really needs to be investigated properly in a clinical trial setting.
So, excuse me, get a little bit confused because the percentage that you're quoting is the percentage that I understand patients with multiple myeloma present with a diagnosis. Because the neurotoxicity that I see with CAR-T is a little bit higher than 5%, and especially depending on the products. So if you're talking about the newly diagnosed 5%, for example, 19 to 20% present with renal insufficiency, 5% present with neuropathy, that has multiple reasons, right? From viral infections that are frequent in patients with multiple myeloma. There's some direct nerve toxicity. And yes, and I agree that, for example, in those cases, people try to avoid proteasome inhibitors, or they try to do it on a weekly basis, etc. If we're talking about the neurotoxicity that we see with a cellular therapy, CAR-T cell or bispecific, we also need to then make sure that we are understanding each other. We talk about the neurotoxicity that happen with mental confusion, aphasia, sometimes Parkinson-like syndrome, etc. And from preemptive dexamethasone that can be used and a Kinra instead of tocilizumab that might have a better penetration to the CNS. Those are maneuvers. But the message here that neuropathy, neurotoxicity, neurologic complications in multiple myeloma is multifactorial. So we need a thorough evaluation to determine which one are we dealing with, and that will be then the best chance of being effective in the therapy.
I was wondering, with the pharmaceuticals, are they preventable? Do they delay the relapse, or is it that they only attack the cancer after it's developed? I guess I'm asking, does the pharmaceuticals delay relapse?
If I understand the question correctly, it's sort of, is the treatment that we administer to myeloma patients, does it actually also delay the relapse? And I think the answer is yes. I mean, the intent, right, is to get rid of as many cancer cells as possible and sustain that remission. That's a way to delay the cancer cells coming back and the need to move on to yet another therapy. And this is why it's both the depth and the longevity that matters. So you heard in the morning the session that was Dr. Osuga's session that was talking about MRD testing. We wanted our patients to not only have good remission, but also the deeper remission. The smallest number of cancer cells left behind, the better. That tend to predict that remission is going to potentially last longer. But he also gave everyone a fair warning that it's not a one snapshot look. Things can change. So once you get to that MRD negative, you want to once in a while check and be sure it's still nice and cool. Same idea on the other way around. If you're not negative yet, stability matters. There are many patients that don't even get to complete remission. They have little bits of the M protein. They go to their doctor's office. Every time the doctor is losing sleep, you're losing sleep. But the stability of that remaining clone matters as well. So, I mean, ultimately, this is to try to keep people in remission as long as possible, because that's not just about the cancer. When people are in remission, hopefully not being on a lot of therapy, if they can be maintained on something, it gives them a chance to have their lives, right? I mean, no one takes chemo just so that I can celebrate the number of their M protein. They want to actually have a chance to focus on other things that's not cancer. So yes, delaying remission, and if we are so good at delaying the relapse. If we can keep delaying the relapse, some patients are never going to have relapse that end up taking their life away. Some are going to hopefully hang in there long enough in remission, and they'll live the rest of their lives and probably pass because of something else, and that's what we want to see.
So most of these pharmaceutical drugs are going to delay relapse. That's basically the end point of most of the studies. There's another term that is time to next treatment, right? Because sometimes you define relapse biochemically, right? You're following the blood, you see some signs of the protein going up, and that is a relapse. Do you necessarily need treatment at that point? Not everyone, right? In fact, you can see a slow biochemical relapse without any clinical manifestation, and it's up to the physician and you to decide at what time do I intervene with any kind of therapy. And I know that it's confusing, but what happens is that disease-free survival is a quick endpoint to determine if a drug is going to be effective. It's a kind of a surrogate of our gold standard, which will be overall survival, right? So if you hear about a product, and sometimes can be confusing, that tells you that you have a 1 year disease-free survival, it's not that something bad is going to happen to you in 1 year. Maybe you're going to get another treatment and you'll be around for many, many years to come. But that is a way that the trials have to determine effectiveness more than anything else.
So while the microphone is going to the gentleman for the next question, or the lady for the next question, I mean, if you think about the wheat story this morning, if many of you, the gardeners in the room, you know, oftentimes, if you can still see weeds in your garden after you've done an application, but it's not much, you might opt to sort of wait a minute, right, to see the situation, whether you really need to load up more weed killers or it's going to actually be okay and stable for a while. So that's what Dr. Rodriguez was talking about. We capture the time that patients get to not be on anything, or the time from the treatment to the next time you need to be on something. So there are going to be some patients that you kind of don't really have a complete remission. You still have a little bit of a measurable cancer protein. You go in, but it's not changing much, and your doctor said, well, come back 3 months. So some of my patients would say, but I'm not in complete remission. Like, why is someone else in my waiting room is already 0 and I am at 0.1? No way to compare across patients, but you get to compare with your own self. And really, oftentimes, stable state of remission is also as critical as if the remission occur, but it doesn't hold just when we're about to celebrate the M protein comeback. Those are the kind of myeloma that get me all up in arm, because I feel that we don't have everything under stable control. So you want stability of the response and hopefully a chance to focus on something else if the cancer is not demanding attention.
Yes, thank you so much for your presentations. My question is for the last presenter that presented about CAR-T therapy. From your presentation, there are a lot of side effects of this medication, and it's so expensive, $500,000 to treat one patient. And they are considering using this drug as first-line therapy. So as a medical student, as a patient, not a patient, an advocate of the patient, will this do more damage to the patient, or is there any markers for you or for us as doctors to say this category of patients will benefit more on the CAR-T therapy rather than the triple therapy or the BCMA that is even known to be less side effects, because you're killing the innate T cells. They become redundant. So more cancer cells, more different types of cancer are coming out of this patient that we are treating. So we are treating myeloma, but patient is getting maybe leukemia, for example, down the line. Is it helpful? That's my question.
Yeah, that's a really good question. I mean, obviously, CAR T cell therapy is not for everybody, right? So that is why patient selection is very important. We need to make sure that we sit down, have a discussion about, what are the risk versus benefit, right? So the data that I've shown is mainly in patients with relapsed myeloma. So in that setting, the risk-benefit conversation is a little different from somebody who's getting CAR at the time of diagnosis. It all depends on the context, but I do agree with you that this is not a benign therapy. It's a non-curative treatment as of now. It's an expensive therapy. And obviously, it's actually the patient and the caregiver who's really it's a long-term, right? I mean, it's a commitment where you have to come and stay and go through all of this. But then we are getting better at managing these side effects. We are learning more about these side effects, right? So I'm hoping in the years to come, we would have known about all the potential side effects. We would have hopefully identified who are the patients upfront who are susceptible to these, and then we can perhaps avoid CAR T cell therapy for for a patient who's prone to some of these side effects, right? And hopefully we'll have better products that are safer than. So it's a balance between efficacy and the side effects. So we know that these are effective therapy, but they are toxic as well. But there are other products that are being investigated at this point where the balance would be much much fair than what we just saw.
Right. So Dr. Subhanasanka presented a slide in where the survival of these patients when they fail to the therapy that we have available. sometimes it's a matter of months, right? There's not even a year survival. So this CAR T had been able to provide a higher percentage of people alive longer than 3 years, right? So the comparison, we know that is beneficial, even though the theory that you're explaining is valid, but when you add and subtract, you still have patients living longer when they were supposed to be gone. So that is kind of the benefit that these new therapies are bringing. And in regard to secondary malignancies, unfortunately, when we have these conditions, our genetics are not stable, and we have the predisposition to develop other conditions, even in the absence of therapy. Because I want to remind everybody that when they came up with the first report of secondary malignancy, secondary to lenalidomide, in the control arm, there were secondary malignancies also. And then last but not least, I went to a facility manufacturing of these CAR T cells. I was personally visiting one, and I walked through the facilities. It is huge, and they look like a space place. So when you start thinking on what it takes to maintain that facility, not only to cleaning the facility, the inspections, regulatory agencies, reagents, I mean, all the staff, and it's a 24/7 enterprise, right? So at 1 a.m. on a Sunday, there are people working on those cells. So that's why it's so expensive. And this reminds me the first trial with transplant. Everybody used to say transplant is an expensive therapy. Now no one talks about the expenses of transplant, right? But why? Because it was a center in where many vendors were coming together to help one patient. The same thing happened with the CAR T. There's some people who construct the vector that are used, other reagents, electricity. So there's many things involved for the benefit of one individual. And when you add in the tab, you end with $500,000. Right? So but hopefully, in the same way that transplant has been kind of getting less expensive, the same thing will be seen with these cellular therapies.
On the cost, so I think the story is evolving, right? So why is it so expensive? Because right now we're making a product for one person at a time. As long as you need to make one product for one person only, it's going to cost a lot because, I mean, to Dr. Rodriguez's point, right, so much go into making that one bag. But the T-cell technology is advancing so fast, so there are already a few products that are going to be made on the shelf that you don't have to collect straight from patients. There are T-cells that have certain parts of them removed, they're still going to be grabbing onto the cancer cells, but the body of the recipient is not going to view those T cells as being foreign. So maybe having shelf products like that would make it cheaper. Now, then there's an issue about, well, if those T cells were genetically engineered, are we interfering with their repair in some way? And they end up causing the T cell cancer in the patients. Well, so what do we need to do? So the technology is now being investigated to be able to put in what we call a killer signal into those T cells that go in. So if they're misbehaving, you just turn on that killer signal, they go away. There are also ways to actually screen for mutation of those T cells. You know, the T cells live in the body as the patients are getting chemo. The T cells kind of got chemo too, didn't they? So there are some mutations in those T cells already. And when we're engineering them, we're adding extra layer of complexity. So ability to screen for the mutations within the T cells and also be able to understand in whom this second cancer would happen will help. Now, there are also these newer products that end up stimulating the T cells in different ways. The T cells expand in different ways, and it feels that there might be less of the neurotoxicity. The number of people who are confused, needing ICU transfers seem like there are less. So take this as this isn't the best products that we will probably ever get, but it is a major proof of concept that this can work in myeloma, can be a lifesaver, even in patients who don't have greatest of choice. And we know that every time that a patient progresses, there is no guarantee that that patient is going to receive next thing and it's going to be a winning bullet. So as the world is trying to figure out how to make the T cells safer, cheaper, and all that, there's also a need to move the T cell technology a bit earlier so that you are able to catch more people. Because if you're waiting until their late lines, there would have already been some patients we've lost along the way. So there's probably not one way that the research community is trying to approach this, but it's all happening concurrently. So this is why, I mean, I think there's a lot of what we are debating about may actually get a little less worrisome down the road.
And to your point about the cost of myeloma therapy, myeloma is indeed one of the most expensive cancers to treat. A pill of Revlimid is about $1,000. Imagine 4 drugs. Bispecific also is an expensive therapy. A year of therapy will be more like close to what, 600, 700K. So everything is expensive. So we need a policy change, really. That's really what we need in this country.